first vital sign that I'm going to measure is Michaela's radial pulse. Michaela, is that okay with you?
Sure.
To do this, place 2 fingers slightly medial to the radius on the patient's wrist. Whilst measuring the pulse, you want to check for rate and regularity. Count the pulse for 15 seconds. Multiply your answer by 4. I counted 15 beats in that time, so that means Michaela has a heart rate of 60. Next I'm going to be measuring blood pressure. Michaela, is it okay if I take your blood pressure?
Sure.
First, remove any restrictive clothing from around the arm and wrap the cuff around the arm with the artery arrow pointing along the brachial artery. Place the gauge somewhere you can see it. First, palpate the brachial artery so you know where to place the bell of your stethoscope. Once you've found this, place the bell of your stethoscope over the brachial pulse site. Slowly inflate the cuff until you can no longer hear the pulse. Slowly release the air from the cuff. The point at which you start to hear the pulse is the systolic blood pressure. Slowly release the air from the cuff, and the point at which you can no longer hear the pulse is the diastolic blood pressure. Michaela's blood pressure is 110/80. The final vital sign that I'm going to measure is respiratory rate. Michaela, is it alright if I have a listen to your chest?
Sure.
While I do this, I'm going to auscultate for 15 seconds, listening for depth of breathing and clarity. I'm going to come onto the left side of your shirt, okay?
Sure.
I'm going to count for 15 seconds. In that 15 seconds, I counted 5 respirations. That means Michaela is breathing at a rate of 20 respirations per minute. Her lungs were clear and her depth of breathing is good. Today I'm demonstrating fracture management. My patient is complaining of severe pain in her left lower leg. I'm going to assess the fracture using the acronym PLUS discs. Can you please score your pain out of 10? 0 being no pain, 10 being the worst pain ever.
8.
Okay. L stands for loss of function. The patient is unable to bear weight and unable to walk. U stands for unnatural movement. When I positioned the patient like this, there was no unnatural movement of the limb. S stands for swelling. The limb is swollen around the area that the patient is saying is sore. D stands for deformity. There is no deformity of the limb. I stands for irregularity. With the exception of the swelling, there is no irregularity. C stands for crepitus. On palpation, I can feel the creaking of the bones rubbing together. S stands for shock. The patient is showing no signs or symptoms of being shocked. Before splinting my patient's leg, I'm going to administer pain relief to minimise discomfort caused during this procedure. My pain relief of choice is methoxyflurane, paracetamol and ibuprofen. Have you had paracetamol and ibuprofen before?
Yes.
Have you had any today?
No.
Because my patient is an adult weighing less than 80 kilos, I'm going to administer 1,000 milligrams of paracetamol and 400 milligrams of ibuprofen. Before administering any drug to a patient, it's important that you check you are giving the right drug to the right patient in the right dose and that the drug is within the expiry date. So Bex, I'm going to give 1,000 milligrams of paracetamol with the expiry date 11/16 to this patient. Can you drug check that for me, please?
Okay, so that's 1,000 milligrams of paracetamol and that's 11/2016 expiry.
Perfect. Okay, and I'm going to give 400 milligrams of ibuprofen with the expiry 10/17. Can you just drug check that one for me, please?
Okay, so that's 400 milligrams of ibuprofen with a expiry date of 10/17.
Okay, and initially I'm going to use 3 mils of methoxyflurane with an expiry date of 10/16. Can you drug check that one for me, please?
We are going to use 3 mils initially of methoxyflurane and it is an expiry of 10/2016.
Perfect. Do you agree with my pain relief plan?
I do.
Have you ever had a drug called methoxyflurane before?
Yes.
Great. When was the last time you had it?
About 2 months ago when I fractured my wrist.
Did you have any adverse effects from it?
No.
contraindications of methoxyfluorine are allergy or hypersensitivity, an inability to obey commands, a family or personal history of malignant hypothermia, known renal impairment, and the patient cannot have had methoxyfluorine in the last week. Now, to take this drug, I'm going to wrap the cord around your hand, and you need to breathe in and out through the whistle. Before splinting, I need to check for any differences in Mary's left and right leg. With exception to the swelling, which I've already identified in my plus discs assessment, there's no other irregularities. Okay, Mary, so what I'd like to do with your consent is splint your leg. This means putting a cardboard box under your left leg and securing this with some bandage tied around, okay? It should help with your pain along with that pain relief I've already given you. Is that okay?
Yes.
Great. Could you give me another pain score? How bad's that pain out of 10 now?
About a 5.
Great. So now that pain relief's starting to take effect, we're going to splint the limb. Before I do this, I need to check the limb baselines. Can you feel me touching your foot?
Yes.
Can you wiggle your toes for me?
No.
Okay. Whilst doing this, I'm also going to check warmth, distal cap refill, and for the presence of a pedal pulse. Now that I've checked the limb baselines are intact, I'm going to get a cardboard splint, a blanket, and some pre-cut bandages. Okay, Michaela, what I'd like you to do is hold the limb at either side of the fracture quite firmly to prevent any movement. On the count of 3, I'm going to get you to lift up the leg. Alright, straighten it for me, and I'm going to pop this splint underneath. You ready? 1, 2, 3. Great, and down. Okay, now can you hold the cardboard splint? Perfect, thank you. I'm going to get these bandages in position, making sure that when I tie them, they won't be over the top of the fracture site. Okay, Michaela, on the count of 3, I'm going to get you to lift that up again, and I'm going to pull these underneath.
Yep.
1, 2, 3. And down. Perfect, thank you. Now I'm going to tie the bandages. Now that the limb has been splintered, I'm going to check the limb baselines again. Can you feel me touching your foot?
Yes.
Can you wiggle your toes for me?
No.
Okay, I'm also checking for warmth, distal cap refill, and a pedal pulse. When assessing a trauma patient, it's important to use the nexus criteria to determine whether or not you need to fit a C-collar on your patient. The nexus criteria include determining whether or not the patient has posterior midline tenderness of the C-spine, any evidence of intoxication, any neurological deficit or distracting injuries, and the patient must be alert and oriented. If any of these criteria are not met, then the patient must have a C-collar fitted. To fit the C-collar, I'm going to ask my offsider Michaela to stabilise Mike's head to prevent any movement during the procedure. I'm going to measure the C-collar from the top of the shoulder to the bottom of the jaw. That's about right. Next, I'm going to explain the procedure and gain consent. Mike, if it's alright with you, I'd like to wrap this rigid collar around your neck to prevent any movement. It's going to be quite uncomfortable. Is that okay with you?
That's fine.
When treating a patient with a non-catastrophic haemorrhage, it's important to first expose the wound. I've already exposed Mary's arm and I can see that she has a 10 centimetre laceration along her right forearm. Mary, is it okay if I use some saline and clean that for you?
Yeah.
Great, so what I'm going to do is I'm going to use a little bit of saline on a small dressing and clean out any debris from inside the wound. Now I'm happy that the wound is sufficiently clean. I'm going to use an appropriately sized combine dressing and place it over the top. Mary, is that okay with you?
Yeah.
Michaela, can you just hold that in place? Sure. I'm next going to bandage the combine dressing with sufficient pressure to control the bleeding. I'm going to twist the dressing every time I cross over the wound to ensure that there is appropriate pressure. When treating a catastrophic haemorrhage, use of a combat action tourniquet is indicated. To use the tourniquet, apply 10 centimetres proximal to the wound. Fasten the Velcro tightly and tighten until the bleeding has stopped or until distal pulses can no longer be felt. If the bleeding hasn't stopped after applying a tourniquet, you can apply a second tourniquet immediately proximal to the first tourniquet.
Once you've applied the tourniquet, document the time and date of its application. This is a very painful procedure, so you'll need to administer pain relief as required.